Hello, this is Robert Lee, and this is a brief review of the role of radiotherapy in the treatment of stage 1 and 2 seminoma. The agenda is to provide a little bit of background, discuss the staging system, approach to stage 1 disease and stage 2 disease. So, the staging system that is commonly used is the Royal Marsden staging system, which essentially stage 1 is limited to the testis, stage 2 is lymph node metastasis below the diaphragm, 3 lymph node metastasis above the diaphragm, and 4 is extralymphatic metastasis. The role of radiotherapy is really very narrow, primarily in stage 2A and very early stage 2B. So, seminoma is the most common germ cell tumor. Even though it's the most common, there's less than 5,000 cases a year. It's a very radiosensitive and very chemosensitive tumor. Generally presents as a painless mass. Workup includes ultrasound of the testis, tumor markers in the serum. Generally don't do a biopsy unless there's bilateral masses or there's a unilateral testis. Further workup, if the man is interested in fathering further children, then sperm banking will be important. The standard approach is a radical inguinal orchiectomy, and at that time then determine from the pathology whether it's seminoma or non-seminoma. I won't discuss non-seminoma further. After the diagnostic procedure, workup includes a CT of the abdomen and pelvis. Chest CT isn't necessary unless there's something abnormal below the diaphragm. Repeat the markers, and if there are symptoms, then consider a brain MRI. So stage 1 seminoma, again, this is limited to the testis. This is just some historical background. This is what used to be irradiated in the 1960s. Periaortic region, plus the ipsilateral pelvis, plus supradiaphragmatic mediastinum and supraclav. We don't do that anymore. So when you look at the evidence for radiotherapy in stage 1 seminoma, you have 3 things to remember. There are 3 trials. Every single one of them was published in the JCO, and every single one of them is a non-inferiority study. So this is the first study, which is basically comparing a dog leg to periaortic alone, patients with stage 1 seminoma. Randomized comparison, 500 patients. You can see that either way does equally well. The next question, again published in the JCO and the non-inferiority study, is dose, 30 gray versus 20 gray. Notice the axis, this is 99%, 98%, 97%. 30 gray and 20 gray, very similar results, and as a consequence 20 gray became the standard to the periodic lymph nodes alone in stage 1 seminoma. This is the last non-inferiority study, basically comparing radiotherapy to carboplatin. Results are very similar. Having said all that, the preferred approach in stage 1 seminoma is observation or surveillance, which basically involves serial physical exams, CT scans of the abdomen and pelvis. If you're going to treat a stage 1 seminoma, probably will only do a few in your lifetime. Patients should be supine. There's no need for contrast. Use a scrotal shield to shield the contralateral testis, and again, if they're interested in fathering further children, have a semen analysis and bank some sperm if they're interested. Here are the NCCN guidelines. Basically, it's a periaortic field, superior border T11, inferior border L5. You can use an arbitrary width. I like to outline the vascular structures, and then depending on how frequently you're imaging, you can make your CTV to PTV margin appropriate. My volumes tend to be quite low, small. I use these retroperitoneal lymph node maps. Now this is from non-seminoma, so we need to remember that. Non-seminoma is probably going to be more hematogenous than seminoma is, but to the extent that lymph nodes are involved, you can see if you have a right-sided tumor, there's essentially nothing involved above the renal vein. Essentially, just about everything is between the great vessels, very little, if nothing, to the left of the vena cava. Right side's a little bit different. Essentially, you can take everything essentially below the renal vein with a little bit up here, but your target is likely to be much smaller. If we look at stage 2, basically 2A, again, remember, is less than 2 centimeters. 2B is 2 to 5 centimeters. In non-bulky 2Bs, there may be a role for radiotherapy, although as soon as they get to 3 or 4 centimeters, then my preference is to do primary chemotherapy, either 3 cycles of BEP or 4 cycles of EP. If you're treating stage 2A disease, then 30 gray is sufficient. If you're treating 2B, then NCCN recommends a 6 grade boost. So this is an example. If you're treating a 2A, initially treat a dog leg, ipsilateral pelvis and the parotid lymph nodes with the margin, and then use a boost to the area of an additional 10 to 16 gray. Here are the resources for the brief video on testicular cancer. Thank you.